Quorum,
We can start, but nothing, we can't take any votes.
can't do any.
Here's Elliot.
Now you have a quorum. Very, I think I'm on time.
Yeah.
Yep, perfect. Happy New Year.
Rolling in right at the bell.
You know, gotta make the most out of your minutes of the day.
So it's a retired guy.
Yeah, that's right.
All right, I'm going to go ahead and call this meeting to order. Review of the agenda. Any changes on the agenda? All right, actually, I see iPad up there. Is that you, Van Smith? Just wait 1 second. I just want to make sure we have everybody accounted for.
Usually that's exactly how she's identified.
Usually, yeah.
Yeah, I think that probably is her.
And is that you and iPad? All right,
Maybe not.
maybe not.
No.
Well, no, not
I
you.
should be-
Sorry,
You
Ann
should see
Smith.
my picture there.
No, you're good. You're good, Ann. The other Ann.
No.
No, okay.
Close it.
All right, so, all right, do we have a motion for approval of the November 11 meeting minutes?
So moved.
I'll second. All those in
Second.
favor,
I'm here.
thank you. Let the meetings reflect.
Ann
Ann
Smith
Smith
joined.
seconding and seconding.
Yeah.
All those in favor of approving the November 11 minutes, please say aye.
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 Hi.
Reflects 4 votes, aye, 1 absent. Do we have anybody lined up for public comment period? Okay. All right. Okay, all right, unfinished business, discussion of substance use disorder and regional opioid settlement board. I said that without stumbling.
It was a mouthful. It was a mouthful.
I'm gonna just show a PowerPoint of just the situation with.
That's
Take this off to help. So this is just some different graphics. This goes from 70 till 1970 to 2009. The number of opioid unintentional overdose deaths, and in the 70s, so the French Connection era and all that, we had heroin as the cause of unintentional deaths, and then cocaine in the early 90s, and then what happened in the 90s that was a game changer, and you've heard a lot about, is that some of the pharmaceutical companies got very involved in promoting the norm that anyone that had any pain should be treated with something to eliminate the pain, specifically what we used to call narcotics. And then you saw at the turn of the century the number of prescription drugs that were responsible for overdose deaths increased considerably and caused a great increase. Next. So that slide went up to 2009. This is 2006 till now, and the opioid deaths by state, you can see is West Virginia, the darkest areas are the highest number. So you can see that this is dispensing rates, excuse me. So the number of prescription opioids. So you can see that increased in 2006 to 2011. But by 2015, some measures to try and decrease awareness of this problem, and then prescription drug monitoring programs where actually who was prescribing what, and whether they were way on the outside of the normal practice. So these pill mills and all that were identified. And you can see that the rates have gone down successively. Notice where the in the early areas and still presently how Appalachia is prominent in the opioid dispensing. Next. So this is since 2000 with the different kinds of narcotics or opiates. Initially, it was heroin, and then derivatives of heroin, where the and now it's synthetics such as fentanyl, or almost entirely fentanyl, is responsible. This is no longer prescriptions are responsible for most of it, but the synthetics. Next. This is the age group, so I guess we all have different ideas of who's affected by this, and we have a stereotype of the drug addict that used to be the inner city African American. So back in the you think of Harlem in the 70s and heroin, that's changed. Now it's Appalachia, it's us. It's a Caucasian person from Appalachia, but it's all over the nation, and it's cities as well. This is a commodity that is sold whether by pharmaceutical companies or organized crime or whatever. There's a demand, it'll be sold. In some ways similar to alcohol and prohibition. There's a demand and people will get it, whether they make it themselves or they import it from somewhere else. And it's not simply teenagers experimenting. People who are addicted, it's a lifelong issue. And as you heard with alcohol, people who are alcoholics, even if they've abstained for 20 or 30 years, they still identify themselves as alcoholics. This is what a substance use disorder is. And so the term now is not drug addict, it's a substance use disorder. It's using something, but it's not in a controlled way. It has now become dominant. And so substance use disorder, alcohol, substance use disorder, nicotine, substance use disorder, opioids. And there are a lot of others, stimulants, but it does include different age groups, including the older. Look at the number of deaths per 100,000 population. Back in the 70s, this was 1 or 2 deaths per 100,000 population, and that's increased a lot. The next.
Increased to what?
So well, that was by ages. So this is Jefferson County, unintentional overdose deaths. So back in 2001, it was less than 5 deaths a year. And now it's pretty consistently for the last years, over 20 deaths a year.
Is that 20 per 100,000?
That's just 20 deaths. So per 100,000 would be more like, 35 or something like that. Next. And that means when there was an analysis of what was in the system after the person died, is opiates were identified. Often there were other substances as well, but opioids contributed. This just happens to be a graphic of Appalachia. All those counties are part of Appalachia as far as the definition by the Appalachian Regional Commission. And this just looks at economics. You can see Jefferson County certainly fares better economically, as we know, but that's a major determinant of health. Despair is often what can lead to health problems, including addictions. It also influences availability of interventions if you don't have good support systems. Next. This is drug overdose deaths. So this is a rate per 100,000. Again, you can see Appalachia there. And this is 2014, next. And 19, you can see that's increasing. As we saw from the graphs, is the number of places. So it's not just us anymore, it's a nationwide problem. And then within all those states that look good, there are pockets that don't look good. On the next. So what drugs are involved next? So the, if you could move the little screenshot down a little lower. Okay, so West Virginia is up tops. If you say that DC is not a state, we're the state with the most, and that's about 90. So you would ask how many deaths per 100,000. So 87 or 90 is the number. If you look at the average for the nation as a whole, that's 34. So we're 2.5 to 3 times greater than the average. And this has been the same for 10 or more years. As far as our leading the pack, DC, interestingly, is right up there with us, and so we are between the heartland of West Virginia, where there are higher overdose death rates than we are, in DC, and we're actually part of the DC metropolitan area. So we look at both of it. There are some differences, of course. Next. If we look at the type of overdose deaths, so any opioid, we exceed DC in that, but again, much greater. So of the 86, 87 deaths per 100,000, the opioids are responsible for 75 of those 80. So it's other things are important, but far and away that's the issue. Next. So the terms narcotic, opioid, opiate, don't worry about them. There are specific definitions, and the definitions actually can change, such as a legal definition of narcotics for law enforcement can include cocaine, which is not medically or biologically an opiate. It's got no relationship to the opium plant. But if they put that definition in the law, then that's the definition. So medically, narcotics mean the opioids because it's something that makes you go to sleep. Cocaine doesn't. But so there are opiates, which are the naturally occurring. So that's opium, morphine, codeine, thebaine, and then there are the derivatives of the natural products. You take the natural product, so you ultimately need that poppy. So you need to import it from overseas where they grow it, whether it's or Mexico. And so heroin was introduced as a derivative, which helped people not get addicted to morphine. It didn't work, 100 years or so ago.
Methadone was supposed to get people off of heroin.
Yeah.
I didn't work either.
Excuse me, I meant morphine, not methadone.
No, I know, but
morphine will make it better. So this is the typical hopefulness. If we just alter it a little bit, it'll be better. But if it gives the same effect, whether high or whatever, as the original drug, there can be the desire to start it or pain relief. But then if it alters the receptor where it binds in the brain such that there becomes a greater need to stimulate that receptor, then that can lead to addiction. So the opioids could include the semi-synthetic, meaning it's the natural one that's altered, or the purely synthetic, and that's the fentanyl. So the synthetics now have pretty well replaced the others. Mostly we're using opioid as the term for everything, that even though some purists will say, oh no, that's not an opioid. It's common speak now. It's language changes.
We've changed the definition of vaccines.
The next. This just shows, I mean, chemically, they're all very similar, their effects are similar. Next. So overdose deaths by state by fentanyl. So almost all, remember, we were saying 86% or 86 deaths. And there was 74 were opioids. So up top, it's 69 of those are fentanyl.
Hmm.
So of our overdose deaths, fentanyl's involved in almost all of them. Sorry, the numbers are so small.
No,
Is
so
that-
I'm actually not looking at the numbers. I
Yeah.
don't see California on there.
Oh, so I may have.
Wow, you're good.
So this may be cut, well.
That's definitely not 50 states up there.
Yeah.
Huh?
That's definitely not 50
So we,
states.
yeah,
Cause I'm just looking at like, again, borders, you know, sort of.
This
border
fentanyl is
states
mainly
stuff.
coming from China, isn't
I'm sorry.
it?
No.
The fentanyl's mainly coming from China.
A lot of it's from, well, it's often imported, but it's so small that it doesn't take, it's very easy to conceal. It's so a small amount, so this, just like the French Connection, it was coming from this way to that way. So that can continue to change. It's something that is easily manufactured.
Yep.
Just like drones, where it's coming from can change. You no longer need the poppy fields to
Yeah.
produce it.
Cause I guess like when I'm by pointing out California, cause I don't see other
I don't.
um
Yeah,
border
there
states
this-
on there.
Yeah, there may not be, but I can
There's no text.
get that information.
No
for you.
Texas,
Yeah.
I don't see Arizona, I don't think.
So some states might not have had that
So I
data
can't-
available. I
And
can't
I'm
explain that.
farsighted,
So,
I can't see that. That's good, you're good.
But we surpassed them all. The total deaths by fentanyl in Texas and California because of their population size will greatly outpace what ours are.
Mhm.
But next. So heroin, we're actually down a little lower, we're in the fourth or fifth state on that. But that's 6.7 compared to, you know, it's a tenth of what it was, so we.
So
we-
it's still saying it's saying rate of overdose, but it's not saying unintentional. overdose. But
We just
still-
don't put that on each slide.
Okay,
Yeah.
so
yeah.
then why differentiate between intentional and unintentional? One might
Well,
argue that people
so-
that are taking these narcotics are kind of like on a death trip anyway.
So I can't speak to the medical examiner standpoint, but they're classified as intentional or not, and suicide notes and things like that. Just so, but people who, you know, or.
An overdose death is an overdose death. I mean, it's a-
Well, car accident's car accident, but it doesn't mean that someone purposefully rammed their car. So this is people who were not planning to die. Yeah,
So they're considered accidental deaths.
it was not a planned death. They planned to take it, just like someone that drinks and gets in the car.
If you were to add the intentionals, would it be statistically significant, do you think?
I'm not sure
If
exactly.
you added purposeful, somebody committing suicide.
So
Yeah.
if you added, if you took the aggregate of all overdose deaths, intentional and unintentional, would it radically change these numbers?
I can't answer that. You know, with handgun deaths, of course, that's a huge piece of it is, you know, planned or not planned, and or, you know, self-inflicted versus but heroin is no longer, it's still there, but the stories that we get talking about the heroin coming up from Mexico, that's changed dramatically since these books were published. It's an important narrative of how things changed in the years next. So prescription opioids, so we're unfortunately, though our numbers have gone down from those earlier graphs, we're still exceeding the nation. I can tell you that that's not as big a problem in the eastern panhandle as other parts of the state. And it is something that's actively looked at, but it's still 17 out of the 89. So it's still significant. And that, again, this means it's involved in the death, it's present. So next. So stimulants, people often abuse more than one medication or substance. So marijuana and alcohol, common, or other pills. So it's not, mixing alcohol and coffee, here, that's nothing unusual to have different areas of the brain stimulated by a drug. So stimulants are common. You can see West Virginia, again, of the 87, 56 of them had stimulants in the system. DC was next. This is where we get into the differences in DC and West Virginia. So West Virginia is just below the average, the overall white bar, as far as cocaine. It's not. It's still significant. It's still there, but not of the 87. It's down to is that 9?
Wow.
3. So
Pretty hard to overdose on cocaine.
well, it's involved in it. So it's but people can't. And so next, so methamphetamines, West Virginia is very high. And on the previous side, you saw that DC was number 1 on it. In this, and I have to verify that this is actually the case. Look at what's at the bottom on methamphetamine, DC. Actually, in the statistics I've seen in the 2021 Jefferson County deaths of those 21 or 20, I think 21 cases, there were none identified with methamphetamine in it. So, and we have not, though you'll see it in the police reports in the paper, someone's possession, it has not been the scourge here that it has been in much of West Virginia, where it's a huge issue in southern central West Virginia. Hope it doesn't become a scourge here, but there is definitely stimulant use, and so I'm a little surprised it's 0. Next. So our ranking, so all drugs were second, but if you go by states and exclude DC, we're number 1 in most of the categories except cocaine. So it's a real issue. Jefferson County does better than many of the counties, but we still face it. Berkeley faces it even more. Next. And that's next. Yeah. So it got better in 2018, 2019, worse in 2020, attributed to COVID, better maybe in 22, but it's not a straight line. There can be ups and downs. So hopefully this will continue. As far as you can turn that off. The interventions, so law enforcement interdicting importation, arresting drug dealers, especially kingpins, but that also involves any user's possession. There are problems with that. First, just like in alcohol prohibition, it didn't stop it and led to problems with organized crime. And so we certainly have issues with that, differences in who's arrested and who isn't, and it doesn't fix the problem for the individual. Going to jail is a great way to get narcotics, and from what I understand, it's there. The other ways are to look at how you can treat the individual, abstinence programs, faith-based programs, 12-step programs, which are behavioral, are important, social supports for those who have addictions, whether they need help with getting a job, which is often very hard. Trying to prevent people from getting problems from, so it's not just the harm of the drug, but all the chaos that causes it. Giving them other supports with food, preventing infections. So one of the great worries is that people who use drugs are more likely to get bloodborne pathogens, hepatitis, HIV, syphilis, as well as other infections that aren't transmittable. But because people will share syringes often, just like people pass a bottle at a party, it's not quite the same thing, but people can use the same syringe if they're in the need. When someone is the effect of the opioids wearing off and they start going into withdrawal, that becomes an overwhelming need to satisfy that. Just like if you can't breathe or you have to urinate, you can be driving in the car, for example, and at some point, if you don't pull over, that's all you're going to be thinking about. And this is not just the bladder, we're talking about the entire body. So people will not care at that point. Do they know what the substance is? Do they know if this needle is clean? So trying to help provide that is this syringe exchange programs, which are controversial because many people think that's enabling or coddling, or that's why people use, but it isn't. The syringe exchange programs are what's called harm reduction. Involves much more than the syringe, but the worry about HIV being passed around is real. We saw it in Indiana a few years ago, I think in 2014-15, and in West Virginia we've seen it in Huntington and in Charleston, and so we're at risk for that.
So syringe exchange, though, is different than safe injection sites, correct?
Very different. So safe injection sites are relatively rare. They so I'm not speaking for or against them, but they would be only a piece of benefit just because of transportation issues. And if somebody needs injection several times, the fentanyl wears off quickly. So if they need to take a hit several times a day, transportation to a safe injection site is not going to be that convenient for many people. So it may be beneficial for some people, but it would just be one of the pieces. So more counseling, more mental health services, detox sites, whether acute or really you need long term. It takes a long time, many months, a year, for the chemical changes in the brain from addiction to reverse. Another way is that people who can't stop for whatever reason is substituting a different. So if you use methadone, there are many people, if they can get a daily dose of methadone, it stops those what we call cravings, but that's not really it. It prevents them from getting the withdrawal, and it's provided for them. They don't need to find it illegally, so they get away from the law enforcement problem. They're not stealing or whatever else, and they then can hold a job and things like that. Does everyone succeed? No. Suboxone, which is a brand name of buprenorphine, is another one that is much more available because methadone has to be given at a specific site that requires a special license. Whereas the Suboxone does not require that. Any certain practitioners with the training can prescribe that. But the number of people available to do it, the Suboxone is different in that it is an antagonist. It doesn't cause the high, the effects that people are seeking, but it prevents the withdrawal. So it's not, so it can be used and sold because it helps prevent the withdrawal. People will buy it on the street, but it doesn't cause the same problems.
So what's the latest on the settlement board and status of that?
So gonna wait for Gino to come in, but my understanding is that it's state-based and that the West Virginia board is not yet completely appointed. Gino had looked up some, so I'll wait till he comes
Okay,
in to finish
He
that.
says, he's got a bunch of media covered up.
you need Jefferson.
Yeah,
Yeah, okay. All right, well, we can skip, is there anything else? We
No.
can skip to the next and we can come
Oh,
back.
just one other thing. So this week we have received notification that our quick response team grant was approved, so we will be moving to hire some staff to help. The quick response team is that when we are aware of someone who had survived an overdose, and EMS or law enforcement would call us and say, this person at this location had an overdose and survived, is that someone from the health department would reach out and see how we can help, getting them Narcan, getting their family Narcan, seeing what else they need, try and hook them up with treatment. It's a step. These are the people at very highest risk. Other people at risk, we can also help with connections. We do have some work with our attorney to try and just be sure that this transfer of information is according to the laws. The status of the regional opioid settlement board.
Well, I think Karen probably might have some information on that. You haven't been able to. I
Elliot
remember
was
Elliot,
okay.
Elliot might be the one who actually has some information on that based upon any
Well, I've
discussions
talked
with
to
the
some
AG.
yeah, I've talked to some people in the AG's office and I'm not too worried about Jefferson County being,
Excluded.
no, not being included in whatever settlement.
We will,
was.
you're under the impression we will be
Oh,
included.
absolutely.
Yeah, well, it makes sense because
We
the
are
AG is
part-
from Jefferson County.
Well,
And actually lives, yeah.
He lives up in
the
Shenandoah,
concern is.
Not that he would give preference. to
Right,
Jefferson.
but he would make sure it's represented for sure.
Well, the
Absolutely.
concern that I have with the health department is. Where will those monies go? Will they allow the health department to increase services for this problem or not? Will it go to the university board? So there are people talking about using this to go to the jails to pay for that cost.
Yeah.
Which is, so it's there's lots of options.
Jefferson County doesn't have a jail. We
It's a regional jail.
Yeah, it's in.
So
it's in
the
Martinsburg.
county has to
Yeah,
fund part
I'm
of
sure.
it, so, but, people are looking at that pot of money. And,
Yep.
Well, what's the association doing?
Yes, so we are working on that. I actually sat next to the Attorney General at a meeting a couple months ago and I asked him directly about
Mhm.
this. And he explained how the boards would. He had some ideas how the boards would work, how they'd be regional, and then they would report to a larger state board,
Mhm.
things like that. But he assured me to the point that he could, that the money would matriculate down to the local boards of health and local health departments. So I don't know how much of that will actually make it to here. It would be great, but hopefully some percentage of it will.
Mhm.
We'll see, but that's one of the things that we're discussing.
Yeah, I was gonna say for
Yeah,
the
so yeah,
association.
the association is definitely focused right now on the legislative session, of course.
Mhm.
But after that legislative session, that's when those boards will start gearing up. And that's when we'll be pressing on
But
those
aren't the
boards.
rules for those boards being
Yes,
made
a-
now?
absolutely. Yes, they are.
So
And
don't we
they're-
wanna be
they're-
on them
they're in
now?
that too, yeah. So I'll be going down to Charleston on the 8th of February. And hopefully I can get some FaceTime with Dora Nauer and others down there, so we can discuss these things.
That's-
We're good.
And hopefully Senator Rucker too. I'm sure you can probably ease my way into that.
Absolutely.
I thought so. Thank you.
Pleasure.
Okay, vacancies.
So social worker is gonna go back up again. I came back in and heard that Dr. Reedy said that finally came through the QRT grant, so that will be a grant funded position, and that anybody who takes that position will know that if the grant funding dries up, that position will be no longer available. So, again, like I said last week, I've reached out to the dean of social worker of the school of social work at Shepherd, so maybe we can get a fresh grad or someone who's about to grad, and someone we can get someone young and energetic to be a part of this, and someone who's really enthusiastic and not quite yet burned out, you know?
Right.
So,
In the sanitarian, I hope to be interviewing several candidates next week.
Okay, because now we're on cycle with the training and. all of that
Yeah,
kind of
well,
stuff.
they're offering trainings in the spring. One's going to be the second week of February, and the other is March or April. So,
We have one new hire though, right?
we do,
Yeah.
yes, well, yes, so.
on what the,
Two technically, but yeah, they
Oh.
both completed they're both fairly new, so
So how many vacancies are still?
just one.
Just one? Oh,
Yeah,
good.
just one
Okay.
vacancy.
Excellent, thank you.
just need one more sanitarian, and we'll have a
Yeah.
full staff, and
Great.
when we get to the report, we can discuss how the numbers have changed on the activity report.
All right, moving over to Charlie.
Hi,
Hi.
good morning, everyone.
Happy New Year.
Happy New Year. So we have 3 reports to go through for this meeting, where we have the October financials to be approved, and then we have preliminary for November and December.
So why is the December still preliminary? I mean, the November is still preliminary?
Because we
Well-
weren't here in December.
Oh, I
Yeah,
see.
you
Okay,
haven't looked at them yet.
I see. Okay, yep.
All right, so October key metrics, bank balance $626,000. And compliance with reserve requirements were in excess of the reserve requirements by $315,000. Accounts receivable stand at $74,000, and $16,000 of that is related to West Virginia Treasury.
So that's trending down.
For now, yes.
For this month, for this month.
Well, one month doesn't make a trend.
Yeah.
Well, if treasury though is also only 16%.
So everything else
20%.
is about 58,000, but nothing more than 10%. It's all small amounts.
All small amount, but still the total other is still now bigger than the treasury.
Right, for this month, and the big one on this is outstanding insurance balances, Medicare, Medicaid,
Gotcha.
and private insurance balances, a lot of that, so those are all one-offs, $30 here, $200 there, $300 there, that type of stuff.
Well, the state treasury, I mean,
That's about to change.
it is, well, I'd say the state's having no problems right now fiscally.
Yes.
And to your point, the state treasurer lives in Jefferson County.
Yes, I used to take the train with them every day to work.
Yeah, I don't think it's a money problem. I think it's a processing problem.
Checks in the mail.
Yeah, I was like, it's definitely not the money in the bank.
Yes, right.
That's right.
Yeah, I go through the receivable reports every month, and I don't think I've seen anything in there over $1,000. It's all very small.
For this month, it's all little stuff.
As far as your budget versus actual, I'm gonna go over just the October, the month of October, how that performed, and then year to date. So for October, income or revenue was $37,000. Salaries and wages, about $78,000, so we're reducing our revenue. And expenditures is about $30,000. So for October, we did see a net loss or a deficit, yeah, of about $70,000. And if we're going to compare that to your budget. Revenue is, well, let me go through the year-to-date numbers, then we can, talk about how, it is comparing to the budget. Year-to-date, we have revenue of $312,000. Salaries and wages, $306,000. And expenditures of $113,000. So again, we're still at a deficit of $107,000. And if we're comparing that to your budget, revenue is below target by about 13%. And salaries and wages are still below budget by 8%. Operating expenses are above what was budgeted by 11%. Several factors for that, including vaccines. So there's this timing difference between when you purchase vaccines and then when you get the money for the services for using them. And then there's also some IT services and racial disparities. You have some grant funding for it's like advertising.
Community outreach, yeah, increased
Community
advertising
outreach.
costs, so we were doing social media. Promotion mostly, but others, and engaged in ad firm, but that's all grant funded and will be
Yeah, so
reimbursed.
it wasn't.
And some of it has been reimbursed, but
Yeah, and so it
Not
was
all,
one of those
but yeah,
things that
there's some.
wasn't, when the budget was done, I don't think it was taken into account, but it's done zero out.
Yeah.
Because you're gonna be reimbursed for it.
Yeah.
So that is October, we're gonna move over to November. Oh, October question?
No, just
Oh, okay.
make a motion to approve.
Oh, all right.
Anyone to second? I'll second that. All those in favor saying, to approve the October 2022 financial report, please say aye.
Aye.
Aye. Aye.
Except.
This is Anne Gwen. I abstain from voting.
I'm sorry, say that again, Ann.
And abstains.
Abstains, okay.
I abstain from voting.
Please let the record note 3 in support of accepting October 2022 financial reports with 1 abstention.
All right, November preliminary key metrics, bank balance, $545,000. Still in compliance with reserve requirements, in excess by $202,000. Accounts receivable for November 2022, about $61,000.
It's down, it's the bank balance is down about 61K. Which,
Our receivables are also down 13K.
okay. Sorry,
No, that's okay. Significant receivables, again, West Virginia Treasury, that is down even more in November, that's $7,000. Everything else is less than 10% of the total balance, and that's almost 54,000. And so as a percentage of receivables, West Virginia Treasury is 12%, everything else is 88%. Then again, for November, I'll go over how the month of November looked, then do a year-to-date comparison with the budget. So for November, we have revenue of about $16,000. Reduce that by our salaries and wages and operating expenditures. Salaries and wages, $79,000. Operating expenditures, about $32,000. Giving us a deficit just for the month of $95,000.
So that's also reduced. Correct. It was
Yeah,
100.
Yep.
Something less than previous.
and
so the combined deficit for the 2 months is like 165,000.
yes.
Oh, so it's, I'm sorry, so it's per month or is
So
it
this is just for
reduced
the
down?
For the period.
Oh, okay.
So for year to date, we do have for November, there is a deficit of $202,000. And some of this is a little bit of matching, because in December, the deficit is less because we had our quarterly billing for West Virginia Treasury.
Which has not yet been received.
Which are good. And we're also hitting the time, you know, we're kind of comparing this to a budget and looking at it in a very, like every period is the same, but that's not how you operate. This is the time of year where, you know, your revenues do go down, and then when the spring comes, you're gonna see an influx of cash.
Well, we've had surpluses previously that brought the bank balances to where they are, which are still
Right.
well in excess of what we need in terms of reserves.
Correct.
Okay,
Yep,
so it's all cyclical.
it is.
Okay.
So.
Still doesn't mean I'm not nervous.
Well, that's your job.
Always a little nervous regardless.
And in November, you had vaccine expenditures of about $17,000. And again, you
Don't
spent
realize.
that, but you haven't realized the revenue yet for that.
That was mostly children's,
Oh, okay.
that one. A lot of children's vaccines there.
Well, wasn't there, did we get a check from the Board of Education?
It's in here.
Any questions on December? Or sorry.
That was November,
Uh,
but that's still preliminary, so you're gonna give
That's
us the
still-
finals
Yes.
next month.
And then we'll move over to December.
With insurance and things like that, we're probably still posting on November because we're still billing,
Okay.
we're still billing for November and December.
So I would expect for those numbers to change a little bit.
Yeah.
And even so, kind of piggybacking on that, even more so for December, I expect these numbers to change. For
Yes.
instance, right now, you know, within the county system, we have the bank balance at $400,000. The bank statement reflects $446,000 right now, so we're still entering
Okay.
in
Yeah.
some of the revenue
Things,
for the
things are
month.
posting.
So key metrics for December, again, very preliminary, bank balance of 400,000. That we are still in compliance with reserve requirements by $46,000.
Getting close.
So
Indeed.
one thing about it, and I'll probably say it again, when we go through. Performance for the month and year to date, there were 3 payrolls for December. And so the normal 2.
Yep.
So now we see an increase in our accounts receivable.
So
and-
the bi-weekly, like on,
Every other versus a 1 in 15 or 15.
Yeah.
Yes.
It's a 26 pay period.
Yeah.
26
Yeah,
pay period
right,
year,
right,
as
right.
opposed to the state, which is 24.
okay, and that's what, on a Friday or?
Post on a Friday.
Yeah, okay.
Today was busy.
For me too.
All right.
Happy New Year.
We see accounts receivable going up in December, about $170,000.
What happened?
Accounts receivable.
Accounts receivable
Yeah.
went from about 50,000, or sorry, 60,000.
And now the big majority of it is the treasurer.
Yes, it is.
Yes, and I'll just to intervene real
Yeah.
quick, three big ones on this one
Mhm.
that were posted in December. One, standard Q3 state aid, which is usually paid at the beginning of the quarter, which is about 104,000. 2 large threat prep. So if you don't know, threat preparedness is now a required service for the Board of Health
Okay.
in the state of West Virginia.
Used to be emergency management.
Correct, but within the health department, it's now a requirement. So threat preparedness, is-
Emergency management still has.
They still have their thing, yes.
One of the key.
and we work with them on a regular basis, quite friendly with them, so.
I hope so.
That's part of the job, and
Yeah.
Mason has a great personal relationship with them over there.
Great.
Steve Allen and gentleman that work there and the young lady that works there, so. There's 2 quarterly billings on that, we incurred costs as per requirement by the state to provide those services and provide preparedness. He's now billed that grant out for those 2 quarters. We're waiting on those. It's probably about 60K. And then one more that is not reflected in this 116 or this West Virginia Treasury, which is about 100 and what, $40,000, $130,000 or something like that. Is I did bill also on the 5th of January, another almost 24,000 for the community outreach grant, which will mitigate the cost of all the large increase in advertising. Trust me, I saw those numbers. I have it. I have all of those numbers highlighted because I
And the source
expect
of funds
questions.
for the grant will be the federal government?
Those will come from the state, but they're a pass through from the Fed.
Oh,
The state already has their money.
Yeah.
They're-
So I said, it's not about the money in the bank, it's
It's
about the
there.
process.
Right, doesn't get to us and how quickly. Sorry to interrupt.
no.
That was good information. So percentage of accounts receivable, 69% is related to West Virginia Treasury, 31% related to others, so anything less than 10%. And so that was $53,000. I don't think I gave you the dollar amount on that. So again, just looking at the month of December, revenue was about $126,000 as of now. Salaries and wages, $119,000, so we're reducing our revenue. And then operating expenditures, we're gonna reduce our revenue by another $29,000, giving us a deficit for the month of about $22,000. Now, looking at a year to date, total revenue, $454,000. Salaries and wages, we're gonna reduce that by salaries and wages by $504,000. And operating expenditures of $174,000. So there's a deficit for the December year to date of $224,000. Just comparing that to the budget, revenue is below target of 20%, which isn't really surprising because, you know, permits are going to be coming in the spring. And that's a big line item. Salaries and wages are still below budget by 8%, and operating expenditures are above what was budgeted by 17%. And a big factor in that is the vaccine.
Who's a vaccine person?
For the purchases.
There's a reason, several reasons for the vaccine purchases was an increased services that were being provided. The number of patients we're seeing is going up.
Is it?
Yes.
And is this like the childhood, is this
It's a
travel, is
combination of
it?
all of them. It's a combination of all of them, influenza, but it's mostly childhood, has been for the last few months, agreed. And then, some went expired. They expired, and so we do get an offsetting credit when we send those back, but it's not nearly the original cost, but we did send it back, we're gonna get about $3,000 back on.
Are we adjusting like our future purchases based on expiration, or is
Of
that gonna
course.
hurt to?
Nope, it's not easy to do, it's,
And when we
it's-
order on one of the conversations is, if we order this, how long?
can we hold it?
Well,
Right.
it's good for 18 months, says, okay, you don't have to order just 2 doses.
yeah,
Right,
especially since vaccines have been stepping up in price over the last
yeah,
year and will continue.
And there are a few vaccines that we used to just order as needed. So if someone called, they said, want to travel, they want a typhoid vaccine, and say, well, we'll order it for you. Now we keep about 5 doses because
Demand
it's
is,
frequent enough that people say, can I get it today?
demand is increased for those types of travel vaccines, obviously with the opening up of the. of
That's
the
not a
world
big
again.
item, but it's a chunk.
And it's not inexpensive, so.
Mhm.
Couple things that I did want to point out here on this, if you go for fees for permit, that's one of the biggest numbers. The environmental side, as we know, is a big revenue generator. So we've barely touched that. We're under 24% of the expected on that. I suspect that we'll take in more than what the budgeted number was.
okay,
Usually that revenue starts coming in
March, April, May,
Yeah.
yeah, those are the big months. And I'm
so
sure,
many people just keep building.
yes, yep, and we still are. And so you haven't seen a decline in what was usual for this time, so.
Knock on wood.
We'll see, hopefully, yeah, hopefully people keep building, exactly. Those are the big ones, and then the other big, the big chunks that we'll be receiving in January. I'm pretty sure, from the state of West Virginia, yeah. I always get antsy this time. I got antsy this time last year too.
Yeah, but.
I was learning at that
I
time
was gonna say,
how
you're
sick,
by now.
how cyclical the revenue cycle is here, or the revenue production is here, so. And also the state, you also have to remember the state aid comes in at 22.5%, 25%, and 32.5% for the final amount, so.
Right,
That it's backloaded for state aid, for state funding, so.
thank you.
Any questions for me?
Anyone online, Elliot? Any
What's that?
questions with Charlie?
Oh, no more questions.
Thank
Thank
you,
you.
everyone.
Thank you.
Charlie, as always.
All right, we will go over to, budget timeline, so, yep.
Yep.
It'll be upon us shortly, quicker than we expect, so.
I think you guys were great last time, but I do want to give you an extra month this time. I presented it in March last time, the very first preliminary numbers. I already have preliminary numbers. I'll present them in February. That way we're even a month ahead of where we were last year, which was already a month ahead, because you guys had actually confirmed the budget and approved the budget in May. So here it
We had to
is.
do that by special,
Okay.
we had to do a special meeting, right?
I did not, that was the
We
year
didn't do an
before.
extra? Oh, I thought we did an extra one this
We
year.
did not.
Okay.
We did it in regular course of business.
Excellent. What's next?
So my very early budget presentation will be February 10th. We'll do a follow-up budget presentation with much harder number, much firmer numbers, including any input from the board. Then we'll present another updated on the 14th of April. With hopefully a final budget presentation and approval at the May 12th, 2023. If there's still lagging concerns, of course, we have the month of June, but it can be no later than the June 9th meeting. Okay, so I want to make sure that you guys have a comfortable time.
It's due to the state.
It's due to the state
June 15.
by June 15th, and I think June 20th at the latest.
Okay,
So, but I would like to get there a month ahead like we did last year. Last year, I presented the first budget in March. Incorporated changes in April, incorporated changes after that meeting, and we had final approval and a final vote in May of last year, a month ahead, which was wonderful. And I think it reduces the stress on the board and certainly reduces the stress on the staff. And probably won't move it earlier to April for the final vote, but definitely plan on May being the final vote day.
Stress reduction is good health.
It is indeed.
Promotes good health.
Also makes you think more clearly.
yes, agreed.
All of it.
Thank you for putting that together.
Absolutely.
Appreciate the organization on that. Doctor's fees. I
Okay.
feel like this is a monopoly thing, increase in doctor's fees.
Yeah, well, we're only considering it right now, but I gave everybody on the board and I sent one to Brandon. It's a real simple, this is called a super bill. If you've never seen a super bill before, this is what it's called. And it is every single line item, medical billing, and including the procedure codes. So what we want to do is we were interested in raising the level 1 outpatient
So one
fee.
pager, I'm very impressed.
Well, there's 2 pages. I didn't provide the second page because there was no changes to that one. It's actually, there is a backside to that. So we want to.
This is one of 2.
Yes, so I didn't want to print that off. Seemed wasteful. Just a $10 increase from 55 to 65, and then for a level 4 from 190 to 200. And the reason why is because reimbursement rates on those have increased through Medicare, but also through private insurances. And as we know, to be able to capture that, we actually have to be charging that to be able to capture that from Medicare and from private insurance. And whenever Medicare make changes, that's when private insurance bases that's what they base their changes on. So
What's the difference between level 1 and level 4?
this is where a clinician probably would be
3
the
levels.
best answer.
So the level 1 is the very simplest. That
Quick office visit.
you know, it almost doesn't need an office visit. or-
Like level 1,
Or-
sorry, level 1 is
Yeah.
that,
it
like,
could
I have a
be-
cough, it won't go away.
That would actually be higher than that,
Oh.
because that's, so it may be something simple, but also it could be. So level 1 would be pretty much never used.
Right.
So it can be something a nurse sees with a practitioner being involved.
Okay,
Level 2 would be a little higher. Level 3 would be a simple visit. And there are there are narratives that describe what goes into each, and the progress note by the practitioner has to support that this was done.
That's like the base rate that's never applicable.
Yeah.
Right, you never get the base rate.
Alex just amusing himself over here. He just.
There you go.
I think learning about the whole,
I'm trying to reduce
The-
stress, less like
the medical side of it and understanding how medical billing goes is actually quite complicated and
It really is.
extremely legislated.
Mhm.
Well, and it's something we have to be good in because it is one of our income lines.
Yes.
Right.
And there is need out there.
Yes.
One of the ways that we can contribute to the health of the community is by providing services that are not otherwise available. Not that we can't compete with others, but there are other niches that we can do.
Right.
Most people have an insurance, even those who are not well off, that they can get. So that compared to 20 years ago, Medicaid does allow some reimbursement. And there's no reason we can't get adequate reimbursement.
Right.
This would allow us to capture the full reimbursement amounts
Right.
through the insurances that we most see, which is Medicare and a lot of the private surgeons, insurances.
And
Blue
looking
Cross.
to future, so we can say, oh, our future budget is going to be based on someone handing us some money, which that'd be great.
Yep.
But also say, how do we make it ourselves? And if you simply look at the, so someday I'll retire, or you'll want other practitioners as well. So how do you offset the,
Cost of the
the
doctor.
cost to have a medical provider here, a health officer? It's gonna be a lot more than what I'm charging right now. And one of the things is
Guaranteed
if they're actually seeing a patient, you need to be billing the same way if they went to any other office here.
Right,
And we'll probably even at that, we'll be billing far less than many of the offices.
right. Okay.
So
You're not
that's not,
looking for-
there's no action or vote.
Okay.
I'll put that on the agenda for action to vote. I just wanted to explain to you, just like last time when we
Yeah.
asked to improve our clinical fees or to raise our clinical fees. And now that you're familiar with it, you can
Okay.
ruminate a little bit and we'll vote on it. Ask them for a vote next month.
Great, thank you. Any questions?
Hi, this is Anne. Hey, the price increase sound very reasonable to me. However, I don't have that chart. Gino,
Okay,
do you
yeah,
mind send
I
me
will
a
send that to
copy
you.
since I'm not there? Okay,
Absolutely.
thank you.
And I'll send one to you, Ann Smith also.
Thank you. All right, agency activities, environmental.
So we do have, one of my sanitarians was just allowed to start working on her own about 2 weeks ago. So they are getting out to do some more food inspections now. So, and our septic inspections has not really dropped any. So we've got 2 sanitarians that are working on that. One is only doing food inspections now. So that number should, you should expect to see that go up soon. I'm working on scheduling interviews for sanitarian for the 1 vacancy for next week. We completed a couple of trainings in the last couple months that are help us to work on our meet our grant goals.
Mhm.
And I am working on, we just completed several grants. 5 different grants that I will be working on filling. So that's about $123,000 that I'll be billing for the grants. So we should be expecting to get that money soon. I also did apply for 2 other grants for the upcoming year. So that's we were awarded both of those, one for 24,000 and one for 7,500 for training. So and that's in addition to the 3-year grant that I got last year that I'll be billing at the beginning of this year because they allow that one to be paid out ahead instead of reimbursable like the rest of the grants. So
Great.
Can you describe the educational session you had for the other counties?
So yeah, as part of our grant funding, we did a couple of trainings. We did one for a backflow prevention course, and we did the FD 170 course, which is not often offered, but it's a base requirement for getting standardized as a sanitarian. The national standardization that we're working on. So that course is hardly ever offered, and it's usually an in-person course. And it was we were able to get work with the state on that, and had 4 other satellite locations where everybody had a facilitator at that location, and there were all kinds of activities, trainings on different types of equipment to use in the field. It's basic inspection techniques that were being taught in that class. And then the backflow prevention, which is something that we are tasked with looking at during our restaurant inspections, but it's not something that a lot of sanitarians are very comfortable with, because it's more like of a plumber's skill set than ours. So that was very beneficial, because it helped us get that much needed training. We also offered that across the state, and there were some satellite locations, and we offered it virtually as well as in person here, so. Yep. So.
And the sanitarian who just got approved to operate, without someone with her, when did she get hired?
What was the name of hire? Yeah, it was shortly before the training started, so.
So it just, there's this lag time that almost every other licensed position we hire, they couldn't even apply till they had the degree. This one, you can't get the degree till you go.
I know, well, I mean, I still think that needs to be changed in state law, but that's just me.
I think there can be some,
Not just you.
Yeah.
I think a lot of sanitarians agree that there could be some
That's
streamlining.
Start doing your book
things like
work
that.
beforehand.
Just streamlining, there is necessary training that sanitarians should have before they work. I was required to have those trainings in Virginia, and they had some similar issues there. They did offer it more frequently
Which is
in
helpful.
Virginia, and they are working on offering it more frequently here.
It's like, I think about other certifications, whether you're like, if you want to go get your captain's license for a boat. You have all your book work to do before and plus your hours, but like, you don't have to be a captain trainee and change your whole career to then do your 5 years of training that's necessary. Like, there's other professions that you can do your book work and then go into your clinical, like, cause obviously the clinical side of it or the field side of it's absolutely important, but
Having training more available is really the key.
Yeah.
And that, because then you don't have this huge lag time.
and it's also,
Quarterly training.
it can
that would
also
make a
reduce
huge
the
difference.
taxpayer burden. Because we're
Absolutely.
paying to train these folks.
And they're not out in the field.
Right, they're not out of the field, and then they go leave.
That's a problem with West Virginia in general, is that the training programs are mainly administered out of Charleston, which is further from here than like Trenton, New Jersey.
Yes.
They have uploaded a lot of the courses onto Blackboard, so they are
It is
utilizing that.
improving.
So they are still requiring 2 of them to always be in person, and I guess the regular trainings like in August, September, October will still continue to be in person. But then the spring, they're allowing the food and the septic to be the only ones in person, and the rest you can take on Blackboard.
That's progress.
Getting better.
What-
Definitely progress.
When was she hired, by the way?
June,
I think it was
June.
June.
April for
That's
Alex.
quite a lag time.
No, Alex.
and that's only,
February.
And then Savannah started around the same time I did, so I think it was like June, July.
but Savannah can only do food, right? She can't do septic.
Yeah, she is, I actually hired her with funding from the grant.
For food,
But she is
okay,
licensed now, approved to
Yes.
do it, just we're not using her in that capacity.
oh, so she is
She's-
licensed for.
Yeah,
food.
she's
Yeah,
a regular sanitarian.
we did go through all the same
Yes.
training as the other
Okay.
sanitarians, because I'm hoping that at the end of the grant period, we're able to retain her. And so.
Yep.
Right.
So
Once
she
the
would
grant
need to
period
have all
ends.
that training. The grant period is the end of 2024, so that was the 3-year grant
Okay,
that she was
gotcha.
written into.
Got it.
So, well, that position was written into also, so.
2 more years.
Mhm.
Yeah, everything in state law is subjugated to, or just hand it over to the Board of Sanitarians, and they get to decide, like state law says, the Board of Sanitarians gets to decide what becomes a sanitarian in the state of West Virginia.
Yeah, that's the whole rules issue. For a lot
Versus
of
it being in
state
state law saying it needs to be this,
Yep.
this, and this, it's, the law says, go to those guys,
Just ask them what,
yeah.
Yep. Let's, needs to be gone through
But
agency
then
by-
providing the training isn't. Isn't the board.
I
that's at
like
the-
that West Virginia has a licensing board, so we get official licenses and.
Oh, I have no problem with the licensing board, I have a problem with the process, the order of operations.
Right,
Like if you're sitting there in your senior year of college, a biology major, a science major saying, what would I like to do with my life?
do I wanna do this?
You know, I would rather sit there and take a course, maybe I'll get credit, or maybe I can just start working on it on my own to do my textbook work. So that I can come to Jefferson County Board of Health and say, hey, I've got at least my book work done, now let me do my field work.
Mhm.
And then you're, A, we're not paying for it, and B, we're getting the people out into the field faster.
well, every state is different,
Mm-hmm.
so, but with that, even in Virginia, like when I worked there, they still required, you still had to learn all the regulations as part of your training, and that's basically
Right,
what
no,
they're
it's-
learning.
And I'm not changing
They
any of
have
that.
they have their textbook requirements already. when
Right, but
start.
they have to be employed in West Virginia
Yeah,
before they can start that. And we
True.
have to pay for that. Because we're
but
their
that's the same
employer.
thing in Virginia.
But I'm saying.
And most
so-
states that do that, that's what I'm
But I'm
saying. it's
saying,
just-
why not change it to say, you know, like. Dr. Reedy to become a doctor was not in a hospital before he started his textbook work. He went to medical school, did his textbook work, did his residency. And then became a doctor.
So you want them to obtain licensure before they're employed?
No, start the textbook work.
Right,
Cause the licensor has two parts. You have the book work and you have the field work, right?
Sort of, it's combined, like.
But you've got
they
book
do-
work and you've got field
yes.
work.
You have on-the-job training in addition
Right.
to the classes.
So why not
that are
allow people to
required.
start taking the classes ahead of time?
Yeah,
What's the harm in
If
that?
the non-practical part, all the
Right.
book learning stuff, if that takes 2 months,
Right,
if you do that before you're hired. It's just like you get your bachelor's before you're hired. In the journal yesterday, it was talking about Jefferson schools and WVU Medicine and Blue Ridge collaborating to train some high school students that will then have a job at WVU Medicine. And this is a little different, but it would be nice if some of the stuff, as they were getting their bachelor's at Shepherd, the difficulty is that unlike the hospital jobs where you always have 12 openings,
Mhm.
you may not have openings, and
Right.
most of the counties never have openings because the sanitarian in that small county has been there for 30 years.
and is also the
That's-
administrator.
and that I think would create a hiring, even more of a hiring issue than we already have.
but it gives an option.
Yes,
Doesn't say you have to do this, it gives an option. And it solves, because again, we've sat here with what, 3 vacancies at a time. Or people that we're paying to get trained. And we have a lag in time for them to be out in the field, they get their training, the license, and then they leave. So. It's which way do you want to solve it? And again, you don't have to do it, it's an option, like you train a nurse goes to nursing school. Before he or she becomes a nurse. You can still go get all your nursing, all your credentials, pass your courses, even pass the test. Although you have your clinicals in between, so it's just. It's not out of the ordinary for licensing to have people having the ability to do some of their training before.
Well, I'll tell you, I was able to get reciprocity for my previous work experience here, but I still had to take at least 2 of those in-person courses after.
Yep.
Even after I was licensed. so.
Right, and that happens, I mean, whether you're a nail technician
so
or a sanitarian or anything else in the state, that's often the issue.
without
And
getting
it's a barrier.
too deep in the legislative process, it sounds like this is a situation where just training needs to be offered more often.
But at least
Really?
you don't have to be a sheet food technician.
Oh, well, that's
I mean,
positive.
but
And nursing
You agree
salaries,
with
the
that,
return on
years, I'm
investment is
sure.
better with current salaries.
Is better?
Than
Yeah, oh, yeah.
sanitarians.
like,
And-
Correct.
And the skills you learn as a sanitarian are not applicable many other places.
Not applicable, but the knowledge,
Oh,
can you
yeah.
create policy? I mean, you look at your trajectory and your career and what you've been able to accomplish, you're now training other people, right? You didn't start that way when you weren't in that position when you started, so you still have an applicability in the policy areas and all that kind of stuff, so.
Well, they're working on promoting environmental health in colleges and there's not that many environmental health programs, and there's not a whole lot of people that decide this is what they want to do before they start working in the field and decide whether or not they like it or not. So it's not the type of thing, like most people don't grow up saying this is what I want to do. So they went as nurses and doctors and things like that. So it's not as well known, and it's not, they're trying to promote it more, but if you go through an environmental health program in college, you can sit for your REHS exam right after college. So you could technically have that licensure.
I don't know what that is,
That's the national certification through NEHA.
okay, so what does that do for
The
us here at the Board of Health?
So basically, if there were more environmental health programs in colleges, it would just help promote more. We'd have people that already have an REHS RS licensure where they could get reciprocity for having that, and then only have to take, they wouldn't have to go through all of the classes before they were able to work in the field.
And another level is getting people to a higher level, so that, like, if Gillian moved to a different job, replacing her with someone with her actual qualification according to that role is very hard to come by.
100%.
So we just need a Netflix series like CSI with
Right.
Mental health specialist. Make it cool.
I think, what's the guy's name? Lowe, not Rob Lowe, Mike Rowe. Dirty
Mike
Jobs,
Rowe.
yeah.
Yeah, I
We
don't
need
know
him
if he's
to,
ever done that.
yeah, I think we should maybe invite him.
Interested.
All right, sorry, not to digress, threat preparedness.
So, oh yeah, we're going out of order.
Am I out of order?
No,
Oh,
from past.
From regular, okay,
Yes,
gotcha. I was like, all right.
Yeah,
We've changed order for a reason.
Change the batting order.
Yep.
it is just that order. I, like Gina mentioned earlier, I was just completing all the billing for the prep grant. And then back in November, I went to an emergency management conference down in Savannah. That was a good experience. Got to live.
Not to be confused with the Savannah meeting.
Not to be
Not the one who works there.
Savannah, they got hired. Savannah, Georgia.
Okay,
Yeah.
all right.
I'm calling HR on him.
Rare form.
Go ahead.
It's just in Savannah.
No, I met a whole bunch of different practitioners across emergency management, and that was a good experience, and that's my update.
Great. Clinical activity.
So this is where we start getting into one of the things that I'm wanting to mention, which is this report was a legacy report that was here before even Gillian started. We went with it, we ran with it because it was there and it was convenient. I didn't find it to be particularly informative. I think when you provide too much information, especially as a board member myself, I look at it and say, that's just overwhelming. It seems like most of that is not necessary to what my role is. And you tend not to get to the pertinent things. So what I'm trying to do is I'm trying to streamline, starting with the clinical services, but we'll continue to do that into the environmental services with Gillian leading that. And one of the things I was asking myself and asking Dr. Reedy and asking the nurses, and we'll now ask you guys, is I think a trimmed down version without all of the onesies and twosies of all the different types of very rare diseases that have been followed up on is probably a better bit of information for you guys than, you know, having just an overwhelming list of all these little different, you know, bacterial infections and things that have occurred in the county. So what I've decided to do is to focus on the things that are programmatic, things that are required by the state on the clinical side, family planning, breast and cervical cancer screening, STI vaccinations and TB, just to focus on the big ones, and then within these, just seeing aggregate numbers as opposed to breaking them out into all their little and parceling them out all in all of the features. So this is really the first of this streamlining that I was hoping to do. And when you get a chance to look a little bit deeper at it, feel free and send any type of questions you'd like to me. But what we then would like to do is to then be able to represent some type of trend.
Yes, I like that. I
Are
like the
we-
fact that you have-
Are we increasing over the previous month? Is there a 3-month average? Is there a 6-month average? Is there a year? What's the annual average? How many people? So that type of thing. So what I'm trying to decide is, now that we've defined what these individual statistics will be and how we will harvest them out of our systems. Now that we have a definition, we can begin to actually have consistent numbers on a month-to-month basis, saying,
Great.
these are the numbers. So we'll start with the January numbers or December numbers. And then we'll go forward from there and be able to have a running average. Would you prefer it just a month over month? Or would you prefer it a month, previous month, 3-month average, 6-month average, yearly average, something like that? But that's something that obviously is going to build now that we've have a much more clear definition of what the statistic means and what it is. So think about that and get back to me with it if you prefer to say,
I think that's a 3-month average or year to date.
be in lieu of just month over month.
Yeah,
So
like I like. the
this month
over
versus
Yeah.
the 3-month average,
I like month over month and then
and then
maybe,
maybe a longer average, maybe
Yeah.
even a 6
So
month.
you can add both. columns.
Yeah, so I have that in there now. I have month over month, and then I have a 3-month
Right.
average. I would like to extend that out once the numbers become more firm and more consistent, that we can then go six months. And then we could maybe have an annual number and say every year, or every month during the course of the year, this is a normal month. So we're above or below what our average is for a month over the course of a year. So I think that's probably a good way to go, but that will take time to build that. This time next year, we'll have an annual average, annual monthly average, an annualized average. So that's something I wanted to ask. So send a questions or anything, or if you think you have some better ideas, I'm wide open to listening to any of them. When it
Instead
comes
of
to this.
previous month, year to date would be better, I think.
Year to date, fiscal year to date,
Mhm.
okay,
Yeah.
put that all in an email for me, and I will
Alright, yeah.
definitely. I'm interested because
And then,
what I'm doing is I'm.
year over year. or
And
so.
yeah, and
That
then
would be-
for an annual
Yeah,
report, so and
that would be-
that's what something Dr. Reedy had given me as a goal.
Cause we get the monthly reports, I can look back at them, just
Sure.
save them on your.
So
hard
they're
drive.
thinking even,
So I could check the previous month, but it'd be really convenient to have a year to date and then a year over year.
in a year, yeah, like an annualized year, yeah.
We can graph it too.
Well, there's all kinds of stuff. So I'm uploading this into an Excel sheet that I've developed, so I'll be able to come up with that. But that's something that now that we have clear numbers and clear definitions around these numbers and what they really are and what they really mean, and we can
That's great.
consistently harvest those numbers. That was one of the things that Dr. Reedy tasked me with when he hired me, which was that I would like to have an annual report, and this is one of the steps that builds us towards that.
I think that's great. But I mean, if the year to date, I agree with Elliot on the year to date, and I don't know that, I would imagine our colleagues probably agree as well. Or maybe don't have an opposition, I think that's just a request is year to date. I don't know, does he need to really follow up with an email on that?
No, I can start running that type of thing, and based on the fact that we do have accurate numbers beginning in December.
That's fine. You can put like a little asterisk saying as of. because we
As
just
of this
started.
date, right?
Because we
We
just
could
started.
have a running total, and then like a monthly average, and then the current number.
Yeah, that's great. It's really helpful.
Yeah.
But
That's
to mention,
Appreciate-
vaccinations have been steady and with a large number of childhood vaccinations. And a good number of flu.
Yeah, I'm a wonk when it comes to numbers.
I am too.
So I'm glad you are, yeah.
That's what my education's in. Even call it Wonk University, so where I went, so.
That one.
As Bevan knows, she's seen the ads on the bus, metro buses.
All right, epidemiology.
Speaking of Bevan.
Oh. Gonna have a quick PowerPoint change.
There we go.
Okay. Okay,
That's
so
right.
starting off, we're gonna be talking about respiratory viruses, kind of what's going on in the county right now. Everyone's favorite, first off, is COVID. The trends are kind of similar to flu right now. We're getting into more medium, high immunity levels. That's to be expected. In wintertime, your immune system's a little bit lower, so that's normal, unfortunately. Same thing can be seen in West Virginia. We go from higher to more green state in October, November, and then December and January. It obviously switches to a little bit more red, just once again, with the winter coming, it's lower immune system, so it's becoming more frequent. In the county, this kind of talks about, there's 190 new COVID cases reported weekly out of 100,000 people. This was taken on January 5th, so it might be a little different now if you look it up. Just to make a note, majority of cases are no longer reported, and so that is not represented in this data, so that's just to be taken into account when thinking of COVID numbers for the county. So this is looking at the actual cases that are in our current hospitals. So this looks at Berkeley, and this also looks at Jefferson. These are hard numbers that we get from the hospitals themselves. So they do a weekly report on how many individuals in the hospital have COVID. So it's not whether they went in for COVID, it's just if they test positive at the hospital. So this talks about the vaccinations for COVID and kind of where we sit with 1 dose versus 2 dose versus booster. We can see 1 dose, we're sitting at 80.3%. People with 2 doses or the J&J vaccine is about 66.8%. And with a booster shot, it's about 31.5%. So this is looking at a little bit respiratory pathogens, but besides COVID. Perfect. So the 3 we're going to be focusing on is influenza, coronavirus, but just to mention, this is not the coronavirus this is not COVID-19. This is different variants. It's responsible for about 40% of common colds. And then we're also going to be looking at RSV on this graph. So as we can see, flu, huge uptick in December. That's normal. It's flu season. It happens every year. RSV is a little abnormal that we kind of talked about in November, it being a big issue. Numbers are dropping back down slowly, so they're becoming more what the past averages have been. And then the coronavirus, mind you, this is only like that's tested, so not a lot of people go and get tested for common colds. So those numbers are pretty low. You can be seen kind of in the stack at the bottom. All right, influenza. So this is looking at the positive influenza tests reported by hospitals. So these are the positive tested cases. It should be noted that a lot of people still don't go to the hospital or get tested for flu, same with COVID. So these aren't 100% accurate numbers, but of those that are tested, that's what is represented. And it did start, the flu season did start a little bit earlier this season compared to the past. And so that should be noted as well. Monkeypox, just a quick note, cases are going back down. They're in the US, they're pretty low, so not back at 0, which was what it was prior to this outbreak, but that's where we're kind of sitting with that. So this looks at the reportable diseases in Jefferson County, just giving a kind of a brief overview. So why are some diseases reportable? So when we look at, I guess when I look at reportable diseases, there's 3 main reasons that they're reported. The first one is it allows us to conduct surveillance. This allows us to determine like why a disease occurs, where, potential risk factors. And then that kind of leads into the second point where if we have that surveillance information, we're able to have some form of prevention. So this include immunizations, education, clean water, proper food, preparation techniques, and infection control as well. And then the third one is control. So once we know the factors that affect those diseases, we're able to put measures in place that kind of keep that at a control level. So like if kind of like with like a food outbreak, if once we figure out what food, we address the producer and then we're able to deal with it at the base level, whereas not so much on the infection level once it already takes place. So looking at the reportable diseases that we had for November and December, this is kind of what we're looking at. We see some salmonella, and Giardia, which is the foodborne. We also see some hepatitis. There's a general amount of tick, but with winter, the levels are much lower. Respiratory, you see the number of COVID cases we get reported to us. And the same thing for December, you see food, tick, and respiratory. And that's it.
So just like the other report, we're changing it to make, we used to have these lists, but they really were not accurate as far as, and we're gonna continue to revise this. Certain diseases are reportable by law, and either the practitioner reports it to the either local or state health department, or the laboratory automatically electronically reports it as soon as it is signed off on. Some of those are evaluated by the local health office, others are evaluated at the state, others are not evaluated at all. So those numbers are not really completely representative of all that happens in this county. For example, Lyme, even at this time of year, that's an undercount. We just aren't notified all of them. And that's fine, because there's not something we're doing different about Lyme, for example.
Thank you.
So about the immune system, about people's immune responses being muted this time of year. Well, just as my own personal, I think it's because, getting enough sun, because the days are shorter, so we're not manufacturing our vitamin D levels. So what I do is I take a little extra vitamin D throughout the winter. That might be a good idea.
So exactly, not to disagree, but to disagree, we don't know for sure that these increases in some of these seasonal viruses, specifically, how much is the immune system, how much is, that's how that virus thrives. There's lots of mysteries. Certainly, with COVID gatherings for Thanksgiving and Christmas, increase the opportunity for spread, but so we look at these trends and then we try and give explanations. We don't know.
Well, that's not what I was saying. She
Yeah.
mentioned that
Right.
immune systems get depressed during the winter months, and I was just.
He was just talking about
I was talking
a
about that.
potential helpfulness in
Right.
that.
Right.
Right.
Like I was talking to a friend of, actually a former schoolmate of mine who works for Pfizer, but she works on the, what is it called? Like the people that like the emergency type products.
Right.
So the non-pharmaceutical type stuff. And she said like that stuff is through the roof in terms of sales because of the supplements of like vitamin C, vitamin D, all of that kind of stuff. Ever since COVID happened, it's not just a seasonal thing, but
Doesn't hurt to have good nutrition.
No, it's always good to be healthier.
Yep. all right, health officer report.
So one of the reasons to move this towards the end is that most things will have already been discussed. I don't
yeah.
need to steal the thunder from the other staff. Just a few things to highlight. So the COVID cases have increased some. The number of beds occupied by people with COVID in the hospital had been up near 80 last winter at this time, between the two hospitals. That's not counting the people seen in Jefferson ED that because of bed availability get sent to out-of-state hospitals with these. But we were down, staying near 10 through most of the year since then. We're up to about 20. And they are sending people out, so they are, seeing more cases. RSV really has waned dramatically more than a month ago, and influenza is going down. Hopefully, like Australia, we only see one peak this flu season. We don't get another one later in the year. We don't know that, so that we do encourage people who didn't get a flu shot, especially those who are most vulnerable to problems, to go ahead and get it. The flu is still there. One big issue for us is the animal encounters, which, it comes under the rabies, because rabies is what we're most concerned about. There are usually less than 4 human cases of rabies in the US a year. And there are not many domestic dogs that get rabies, but it still happens. Rabies causes about 60,000 deaths a year in the world. We just don't think of it, but rabies is common in this area and much of the United States because it's there in wildlife, especially raccoons and feral cats. And we do have encounters with it, and our pets who go outside have encounters with rabid animals. If they aren't vaccinated, they can get rabies. If we looked at the report, we had one specimen sent off and 2 came back positive, and that's because 1 was sent off from out of state, came back positive. This was actually an owned unvaccinated dog who developed rabies. And the problem is that if that dog then was exposed to people and other animals, it doesn't have to be just a bite. When we think of, oh, I got bitten by a dog in the park or a feral cat, but if you've got it's transmitted through saliva. So if you've got a domestic animal that is licking your face and has rabies, it's saliva to mucous membrane. So it's more than bites and scratches. The usual way is bites and scratches. If you travel, overseas, don't pet the dog.
I was gonna say Elliot needs to stop his raccoon wrestling ring
Yeah.
that he's operating. Sorry.
All my outdoor animals, that go outdoors, they're all vaccinated for rabies. That's one of the vaccines that actually work.
That's responsible, that's responsible dog ownership. That's what we should hope for.
As we think in threat preparedness, one of the issues, not thinking just of humans, but human behavior is if I need to go to a shelter,
Where do my animals go?
if my animal can't come with me, I'm not coming. Well, your animal can't come in the shelter if it's don't have proof of vaccination.
Correct.
And so these are things that you have to prepare that infrastructure. You have to give population to do it, and people have, like so many things, I need to floss, I need to do this, I need to mail, I'll do it later. I'm not going to, but this becomes important. So it's something that's hidden. It's an important part of the environmental staff because people love their pets more than they like their kids sometimes. Want to be
Some cases I don't blame.
I don't have anything specifically.
Okay.
One thing I'd like to just note is that I yesterday sent an email to you and copied the members regarding the Bears database. I don't want to discuss it now. I just want to make y'all aware of it because probably nobody's had a chance to take a look at it. At some point, it's a subject that's going to come up.
I have not had a chance to take a look at it, so I'll come through.
Okay.
Health administration.
Quick and easy, down and dirty. Annual audit report should arrive soon. Usually arrives in January, February. We got a clean verbal report, but it's much more important that we have a clean written report. When I receive it, I will send it out to former fiscal year 22 board members to make sure that they have their copies too, so that they can know that, they were responsible during that time. But since there's no gigs, we think we'll be happy with that. Still working on broadband internet for the office. It's actually beginning to start now.
Good.
It is now inside the building.
How
They are going.
How do I get it?
That's coming. It's not there yet though, but we're getting it. It's coming. So they're gonna set it up without us receiving our 48 port switch is what I'm receiving from the West Virginia Office of Technology. So that's good. I want to thank all the Board of Health members for helping us update the Board of Health bylaws. So we didn't look like we don't know how to spell and use grammar and punctuation. So I took the updated bylaws and had them recorded with the county clerk on December 20th at 10:30 a.m. So they've been recorded. So we have the current bylaws recorded with the county. If you have not met our new LPN, her name is Sherry Walker Fritter. She's a wonderful person.
Lindsay's gone.
No, this is our new LPN, not our nurse director.
Okay.
She's a wonderful person and an experienced nurse. She was a travel nurse for many years, so she has seen a lot. She's quite good.
Would Lindsay normally be attending these?
She's actually in the clinic right now working.
Oh, okay.
So, but yes, I would love for her to come So, but today she's actually working in the clinic. Everybody who sent food to the Christmas party, thank you, Karen. And those who attended, Elliot and your lovely wife, thank you. And also Ann Smith for attending and bringing some amazing cranberry and walnut Brussels sprouts,
Yeah.
which were outrageous. And I'm stealing that recipe, so. That is all for me, though.
Great. All right, well, we've got the next meeting scheduled for February 10th. I unfortunately am traveling for work and I'll be in a not advantageous time zone. So, unfortunately. I will
6
not-
a.m. No?
Yeah, exactly. Cause I have a very early start in the meeting in said time zone, so, I won't be here, so defer to your leadership.
Yeah,
Yeah, you're on the hook, man.
no problem.
On a lot of movies like this.
Is there a motion to adjourn?
So moved.
All those in favor of adjournment say aye. Aye.
Aye.
All right, we are adjourned. Thanks, everybody.
Thank you, guys.